I just thought it would be a little bit fun for us to have a little musical interlude to our morning. And I just wanted to say that I used to joke about our very first Fraser Health FLS team and call them the Mission Impossible team. Because back in 2012, and I realized that that was 10 years ago, when we first started thinking about FLS, it really seemed like a daunting task to bring FLS to BC for the first time. And if we fast forward 10 years, things look a lot different. And we have a new mission. We have a mission to spread FLS across BC. And it is now very possible, I think. So over the next 30 minutes, I'm going to really be telling you a bit of a story of the development of FLS over the last 10 years. And it's not just my story, it's the story that belongs to a lot of the people here in this room. I'm just really the spokesperson today. So I really don't have much in the way of disclosures. Everything I do is pretty much on a volunteer basis. Except when I work clinically. And you heard Larry's story, and I have a story as well. And it all started in the 25 years that I worked as an emergency room physician, mainly at Peace Arch, but also a few years in Montreal. And, you know, I saw a lot of patients like Larry and like Cheryl and like Margaret, some of our patient partners here. And I knew we did a great job of taking care of their immediate fractures, but I really started to wonder why we weren't doing something to prevent that second and third fracture. And believe me, those people, they came back. We did see those second and third fractures, those familiar faces that kept coming in. So like Diane, I did try some models that didn't work, and we didn't publish any of that data. But fortunately, I didn't wait 15 years to start looking at the FLS model. And in 2012, that's when I first met Diane. And as you realize, she is very short. And so I saw her kind of poking her head above the podium and talking about FLS. And that was the first time I really heard about FLS. It was at an OC forum in Toronto in 2012. And so I was super pumped, I was super excited, and came back to BC and started to bring together a team. And so that's what happened in 2012. We developed a core research team. We put together a proposal to the Canadian Institute for Health Research, or CIHR, and we were happy to discover that we got the grant. And for a year, we worked together to look at all the different models. We looked at the evidence at the time, and we had a lot of help from other people. So Dr. Bogash came out to Vancouver at that time, and we also had people coming from California, the Kaiser Permanente program, which is had also been sort of one of the front runners in FLS. And we got some input from the programs in the UK and also in New Zealand. And we took a look at the FLS toolkit that Diane and OC were developing. And decided that we were going to implement an FLS. Peace Arch seemed like a logical place. We had funding from the Peace Arch Hospital Foundation to get it going. And between 2014 and 2016, we developed, ran the prototype, and did a before and after study. And so in 2017, we got it permanently funded, thanks to Teresa, who we'll tell you a little bit more about that story. And of course, we were the first star on the OC National Registry map for an outpatient FLS. And there's many people here in this room who were on that original team. You'll probably recognize a few of the names. There's David Whitehurst at the very back of the room, Dr. Kirsten Gustafson, Larry Fennell, and as we moved into implementing, Dr. Ashton Tiberia was also involved as well, and he's here today. And I just wanted to highlight that in the end, one of the most important people on our team was the new FLS coordinator, Nancy Parmar. And we had several research coordinators that worked with us over the course of the project. So in 2015, that was our launch date. It was February. It was very close to my birthday, so I always remember it was February. And again, just wanted to highlight over here, this is Nancy Parmar. She's a nurse practitioner. And she's the one who really developed all of the processes and templates that we base our FLS programs on now. It was a 3I model, so nurse practitioners can prescribe. And it was 3 days a week in the outpatient clinics only. And Nancy worked very closely with our orthopedic surgeons, the 3 surgeons listed here, as well as our CAS technicians. So for those of you who've got CAS technicians, they are a very important partner in an FLS development and just in all the communication. So I'm just going to briefly show you some of the results from our before and after study. We have published the study, so it is referenceable. And we recruited almost 200 patients. Remember, maybe a little bit younger population than you would imagine, but remember this is outpatient only. The most common fracture, not surprisingly, was a wrist fracture, but we did actually see a lot of hip fracture patients too as they were coming in for their orthopedic follow-up. And again, just as Diane said, a third of our patients had had a prior fracture and had never been investigated and or treated for osteoporosis. And our primary outcome was what we considered to be appropriate care. So in patients that we determined they were at high risk of having repeat fractures, one or more of the following had to happen within 6 months of their fracture. Either an osteoporosis medication was started, if they were already on medication, that was reviewed to decide if they needed a change in medication, and or a referral to an osteoporosis specialist for a very select group of patients, and we had particular criteria for that. So these are our results. I mean, we didn't even really have to do statistical analysis to see that there was a big difference. And what is really impressive, I think, is that these are the same kinds of results that others have seen elsewhere. You know, we saw almost more than a threefold increase in the number of patients who received appropriate care if they were high risk for future fracture. So it's really nice to be able to compare back to the world literature and see that we're doing just as well. And one of the things that I'm just going to briefly mention, again, somebody had brought up the issue of bone mineral density testing, is that we did see that people went for their bone mineral density tests, and I think a lot of that was because we could give them an appointment right there and then at the visit. A secondary outcome that we looked at was referral for falls assessment. Now, again, in the outpatient clinic, you're not going to see a high proportion of patients that are having multiple falls. It was about 9% in our FLS program, but in our control group, not a single patient was referred for any fall prevention assessment, even though when we looked at the groups, the control group had actually a higher number of people who had had 3 or more falls. Our patients loved the program. We did patient experience measures, and you might not be able to see it that clearly on the map, but 30% of our patients rated us as 10 out of 10. So that was really gratifying to know that their experience was good. And this quote just is representative of how much the patients appreciated the time, the information that was provided to them. So just touching on a few things that were keys to our success. I think the full support of the orthopedic surgeons and CAS technician was super important. And the fact that we integrated it directly into the clinic. So the patients don't even see it as a separate program. It's just all part of their orthopedic visit. And initially, the orthopedic surgeons, we were a little bit weary. You know, how is this program going to interfere with my flow in the outpatient clinic? Is it going to slow me down? Am I going to be seeing less patients? And I'm talking to you because you're the only orthopedic surgeon here. But you know, they are now our biggest advocates. They were just so thrilled to have somebody who would take that piece off their mind so that they didn't have to worry about it. And one of the things that our orthopedic surgeons have done, which is not something we ask them to do, that after they see the visit, they say, now I want you to see this nurse because this is very important. And so here we are, we have an orthopedic surgeon telling the patient that it's really important for them to follow up on their bone health. And they specifically mention that at the end of their visit. So since 2017, FLS has been a permanent but part-time program, 3 days a week in the outpatient clinic only. So then we thought, well, what's next? I mean, we've only got it at one hospital. It's just a drop in the bucket at the moment, right? So what can we do from a provincial basis or even in a health authority basis? Because our health authority, Fraser Health, has a lot of hospitals that could be benefiting. So just at that time, the Michael Smith Health Research BC, that's what it is called now, the new title, announced their first implementation science team competition. And for those of you who don't know what implementation science is, because I didn't when I applied for the grant, I had to learn. It's a new type of research that specifically looks at how does an intervention that's evidence-based get into practice? Like what's the process that you move it into day-to-day practice at the front line? So with a new project, we had to bring together a new team. And so we had partners from all of these different areas. And we developed a co-lead situation. So I am the principal investigator, but my co-leads are Tanya Bugala, who's the Dean of Health Sciences at Simon Fraser University, and then Larry Fennell, who you heard earlier. And we were the only team that had a patient partner as a co-lead. And Linda Dempster was our executive sponsor. This is our research team, and there's many of our research team members here in the audience. We have researchers from UBC, SFU, as well as within Fraser Health. We have an additional partner, who's our official photographer today, and several decision makers. And really important to note that we now have a Ministry of Health partner, and Stephen Smith decided that he wanted to join us, and he's still with us. So I think that's a good sign. And we have Teresa O'Callaghan, who's our executive director, decision maker, and a few other decision makers from other departments within Fraser. And of course, our two research coordinators who've been running around making sure that our day goes smoothly, Evan and Monica. Now, we were successful, just in case you weren't sure whether we got the money. There were 5 teams that were funded out of the 10 that went through the initial screening process. And so the objectives of our new project were to try and look at developing FLS models that might work in different types of settings. So these are choose a smaller community-based hospital. What about a tertiary care hospital like Royal Columbian, or a rural hospital that serves a lot of rural communities, and also a large proportion of the patients come from Indigenous communities as well. We wanted to learn from our experiences, so that's the research piece. And our ultimate goal at the end of the project was to develop an implementation plan that could be used to spread FLS across BC. And having this meeting today are deliverable. So we were able to do it. At each new hospital, we undertook some pre-implementation activities. So we looked at some of the administrative data to get a better picture of how do patients flow through the system, what are the orthopedic processes at that particular site, because they do, of course, vary from hospital to hospital. And then we did key informing interviews with some of the health providers and administrators at the sites to better understand what were the facilitators and barriers to FLS implementation from their perspective. And we did them before, and we're now doing them after. So we haven't finished our work yet. So the first hospital site that we started at was Royal Columbian. And we do have one of the key champions, Dr. Dale Clayton, here in the room. And Dale had been trying to do a number of activities improve the care and management after fracture at Royal Columbian Hospital. And I think had the same sort of story. I saw him nodding his head when he said that at first those referrals to his practice were coming quite quickly, and then they kind of just dwindled and almost disappeared. Am I right, Dale? Yeah. So with the increased support that we were able to get through our implementation science project, we brought Dale back in and helped to support him with some of the orthopedic surgeon champions. We had the executive director, the director, the manager, the nursing lead, the PCC. They were all on board, and we did a lot of presentations. We did orthopedic grand rounds, and then something came up. There was some funding that came available for some nurse practitioner positions to start working on the orthopedic outpatient unit. So we thought this is a great opportunity to start a hip fracture FLS. And we got commitment from professional practice to incorporate FLS into one of the NP positions. So everything looked great, right, Dale? But as you know, best laid plans can get derailed, and we do learn from our mistakes, our failures. We learn a lot. And the executive director, director, and manager, they left almost all at the same time. And so we tried to re-engage. We were unable to meet with the executive director, and Larry knows we tried, I think, 3 times. We did manage to meet with the new director and manager, and they were supportive, but they were distracted by other priorities. COVID was just starting up. Then the integration of the nurse practitioners ran into problems with how they were going to work on the ward. And so eventually, after 6 to 8 months of us waiting for when is the right time for us to start working with the teams, those positions went to another department. They ended up not even coming to the orthopedic board at all. And so our plan fell apart. So what did we learn? Well, we learned a lot of things. I just tried to summarize a few of the key learnings. I don't think we fully engaged the new leadership team. And I think one of the things that came out in some of our interviews is that maybe there wasn't enough of a Royal Columbian Hospital face to the initiative. Some hospitals, they really like to do their own thing, and they don't want to necessarily learn from others. They want to have it coming from their own people. And it just highlights that, the importance of having a dedicated FLS coordinator that's hired specifically for that purpose. So we were trying to piggyback onto something that was already happening, and it didn't go through. So hospital, big politics, and they did have a big role in the COVID pandemic, and we're also going through big renovations, new buildings and everything. So there was a big construction going on at the site as well. But there still is a lot of enthusiasm to keep trying. And I'm so today, and I think the orthopedic surgeons are also still very supportive of FLS at the site. So stay tuned for news. Now you heard about the Brookfield chair. I think the Brookfield chair has been a huge mover and shaker of FLS in BC. So I just want to emphasize how important the chair was to the further development of sites, at least within Fraser, and also is going to be, I think, a big mover within the interior health as well. So Chilliwack Hospital did get approved for 2 years of funding. And so the first step was to try and go to the leadership of Chilliwack Hospital and secure some buy-in. So with the help of Petra Party, the executive director, we had a Zoom meeting in February of 2021. And I think within 15 minutes, they said, where do we sign on the dotted line? Let's get going. They were so enthusiastic. And Robert Stam, the manager for seniors programming, was identified as kind of the operational person that was going to move things forward. So this is how the rollout happened in Chilliwack. We started doing all of our pre-implementation work. The Brookfield chair, Mel Zoo, with the Chilliwack leadership, so that's Earl. And then over the next few months, we just started connecting with some of the key people, primary care, Aboriginal health, a little bit of a site implementation team was created. And then in the summer, a nurse was hired, and that's Mike, who's going to be talking to you after I'm done. We started advertising to make sure that everybody knew what was going on, and we were they were going to start first with an inpatient FLS. And I just wanted you to notice that there's just 1 year. They went from the first meeting in February to starting their FLS in less than a year. So that is just, and they quickly started moving into the outpatient as well. And so in early 2022, they got their star for a combined FLS program. So that was fantastic. And so for the first time in several years, we were not alone at the And then, as Earl mentioned, we did get some additional funding through the Brookfield chair in discussion with Earl. We thought, well, if there's more FLS coming up, we need to develop a bit of an FLS training and mentorship center. And so now we have full-time funding for the FLS coordinator at PSARCH. And we've started developing some training, and we've developed a BCFLS toolkit that we've shared not only with Chilliwack, but the next team that's coming up soon. So we got an upgraded star on the registry to be inpatient and outpatient this year as well. And so just at PSARCH, Tajinder Rangi is our permanent coordinator. She just had a little baby girl. And so we have Serena Bradmore, who's been trained up. She's doing a fantastic job. She's in the back of the room here, and she'll be doing the PSARCH Hospital FLS program at least for the next year and a half, 18 months. And then you have the, I won't mention too much because Mike's going to talk quite a bit about their team shortly, but Mike's done a fantastic job working closely with Derek. Who's been a great FLS medical lead. So that's Fraser Health. But meanwhile, in a health authority far, far away, actually just next door. But you know, we always joke about how the health authorities are so different, right? So they're in Vancouver coastal, which Fraser Health always says, we get all the money. So another group of dynamic and dedicated physicians was really creating a stir to start an FLS in Richmond Hospital. And I'd like to think that Dr. Leo Lai, who was here in 2018 at our last FLS forum, might have had a little inspiration from the last forum that he brought back to Richmond. So made a little timeline for the Richmond group as well, based on the information they gave us. And in some ways, they followed a little bit the same format that we did, in that they've been talking about it for a few years. But I think where things really started to ramp up was right here in February of 2021, when they did grand rounds and got a commitment by the senior leadership that, yes, we want to move ahead, and we're going to give you a project coordinator to develop a business case to move forward. And so that's what happened. Between March and November of 2021, the business case was developed. They presented it in November of 21. And I got a phone call from Dr. Rahim Karani one night saying, we got it, Sonia, we got it. They not only approved for a full-time coordinator, they actually gave us a research coordinator, and we never asked for that. So I think they were absolutely ecstatic. As was I as well. And so 2022 has really been a process of starting up and laying out all the processes. And I'm happy to say that they just managed to get it going and get their star on the registry in October. Now, although their timeline followed a similar pathway to ours at Start, I think something that was a little bit different is that we used a lot of research funding, we used hospital foundation funding, and I think it's really quite remarkable that this fantastic team were able to secure spike funding for their FLS right off the bat. So I think we have a lot to learn from the Richmond group, and this is their team. I've tried to star the people that are here in the room, including Maggie, who you haven't put on the list, but I added her on because she's the coordinator. And this is one of the communication tools that they have used at the hospital so they get the word out to the hospital staff. So in just the last year, we've gone from 1 FLS to 3 FLSs and 2 health authorities. So that's a great achievement, I think. The other thing that happened is that the Richmond team has joined our research as well, and Dr. Ricky Crane has officially joined our team as that link, and so we're really looking forward to that. The other thing that's happened, and I'm sorry it doesn't show up all that well on the screen, but over the last 2 years, a BC coalition of osteoporosis physicians has been brought together under the leadership of Dr. David Kemler. And within that larger group, we've created an FLS special interest group, and we have 5 hospitals that are represented there from 3 different health authorities. And I co-chair that with Dr. Karani. And so this is a great opportunity for some of you in the room who are interested in moving forward with FLS to be able to join this group. And we meet by Zoom roughly every 3 months. So what are some of the key learnings? I mean, there's lots I could say. I was trying to condense it into a few slides here. Top of the list, of course, is funding. I mean, you need funding for a coordinator, you need funding for the medical need and clerical support, and I think that Hillary talked about that. But I think one of the things that Richmond brought up is that team members' time. So they were very good at getting funding from some of the funding pots that are available for physicians under facility engagement, which is something that occurs at pretty much all hospital sites in British Columbia and allows physicians to be paid for the time they spend on work. And then there's also funding from the health system redesign funding. So there's lots of opportunities for people to get funding, particularly for physician time. And that may be changing over time, and that we're going to be able to also fund allied health to partner with us. And Teresa might talk a little bit about that. There's also a new initiative, the Specialist Services Committee Spreading Quality Improvement. This is brand new. I just got an email last week about it. And this may be something, again, that we might be able to use at some of the other sites. And I just wanted to highlight that the development of a business case is really critical. And I think Richmond did an exemplary job, and a template that, if they're willing to share, could be used at other sites as well. Another key learning, of course, is the team. And, you know, together everyone achieves more. I think that goes without saying. And although physician leadership is essential, it isn't enough. You definitely need that multidisciplinary team with the decision makers, patient partners, other healthcare providers at the front line, and even researchers and policymakers can really help as well. And I do think you need at least one team member that is well connected within the hospital. It is really hard if you're a physician working completely outside the hospital to get something like that going. So you can be the champion, but you do need those connections within the hospital network. Keep a flexible approach. I mean, you've got the big picture people, and you need those at the beginning, and then you need those detail-oriented people that can actually get things done and remind you of some of the barriers that you may need to overcome. Again, just engaging decision makers early and often. We have decision makers on our team right from the day one. And one of the things that we did after we implemented the FLS at PSARC is to invite one of our administrators to join us as a champion on our team, and that's been very effective. Engaging and integrating patient partners into your project. I've been a firm believer in having patient partners in research and in quality improvement projects. You know, their lived experience to help guide us is so important. And the other thing that we didn't really realize at first is how important those stories were in influencing decision makers. And I think the Richmond group found the same thing. It just puts that real human face on what FLS is all about. I think some pre-implementation planning is so important. And then the broad stakeholder engagement. You have to engage those people that are potentially going to be affected or involved, even in some way, with the FLS program or the coordinator. And at PSARC, we did focus groups actually with a lot of these groups. And I think Kirsten, you remember all the ones that we did back then. I also want to highlight that the quality of your FLS is actually equivalent to the quality of your FLS coordinator. So that FLS coordinator hire is super important. We did have a nurse practitioner, and that did seem to be the ideal fit. But we went through 3 nurse practitioners because we couldn't get one to stay in the job. And part of the problem was it's too narrow a scope for them. And in BC, they really want to be doing general primary care. So we've all 3 FLS programs are now nurse-led. And a preliminary look at our data has certainly shown that we're still getting really good 1I, 2I, and 3I. Maybe a little bit of a drop in the 3I, but certainly still far better than what the status quo is. And I just listed a couple of qualities of the FLS nurses, and that's just based on some of my experience of some of our other FLS leads too. Mentorship and collaboration is really important when you're starting out. And the FLS Hub, led by Diane Theriault and Wendy Schenkels, was an invaluable support to us, and I think to all of the current FLS programs. Our team has certainly been sharing everything that we have elsewhere, and I'm really looking forward, now that Richmond's up and running, us being able to collaborate more and share and learn together. So for any of you looking to start a new FLS, you're not alone. And then finally, the quality improvement, and that's already been touched on, so important. And if any of you are interested, there was an international webinar just recently done in September, and we now have the audio link so that you can even see how things are being done in other countries. So in terms of continued development, again, I think there's been a lot of work to develop core competencies for FLS coordinators. I think there's more work that we can do as we move forward. One big thing on my list is to look at expanding the scope of practice for the coordinator nurses, just like they have in Nova Scotia, to be able to order x-rays, order labs, and even prescribe. Wouldn't that be awesome? Ongoing mentorship and training, not only for the FLS coordinators, but I think also for the medical leads. The role of allied health to support FLS activities. We do have a physiotherapist who works with us in the Healthy Bones Clinic, and also it works in our fall prevention clinic. And we have a pharmacist here from PSARC as well, Caroline. And so, I think looking at how all of the different professions can just support the FLS activities. The other big thing that's coming up, many of you know that there's going to be new osteoporosis guidelines coming up. They keep telling us they're coming. I don't know when they're actually going to come, but I'm thinking probably within the next 6 months. And we may need to make some adjustments in our toolkits to reflect those new guidelines. So just in summary, we've had a huge progress from 1 FLS to 3. We've ticked off a few boxes around developing a toolkit, developing a special interest group, and also doing some research work. So what next? I'm happy to report that we have at least one person in the room from all of these 4 health authorities. And so I think it's really exciting. We're still missing Northern Health, but maybe in the next 4 years, they'll be here at the table as well. The other exciting thing is that we have 3 people here from the Ministry of Health, and that's the first time, at least in BC, that we've been able to get ministry people to join us. And there's some very exciting initiatives looking at doing modeling work around sort of the cost benefit, cost effectiveness of FLS, not just on a site-by-site basis, but across the whole province. And also some research work that I'm going to talk about later this afternoon. So this is my vision. This is our vision. And I think anything's possible. We've got a great dynamic group of people here, and I know each one of you are going to take messages back from today. So that's it.